Y'all's exam is Monday, right? Okay, and then y'all start CPR Tuesday, and then y'all know we have a long weekend next weekend.
Yes, I'm so
Oh, okay.
excited.
Yeah, so we'll probably we'll skip Easter weekend and we'll probably pick up with cardio the following weekend. What's interesting is now there's a big shift. I guess there was a shift from FTM to MSK, like a different study style. But what I enjoyed about CPR is it's really, you get into clinical medicine. It's much more practical. To a degree, it gets more difficult because you're not focusing on questions that are buzzwords. You're focusing on actual clinical scenarios. But so just be aware of that. It is kind of a shift in your study style. And but it's interesting though. It's kind of like you're actually talking about stuff that you're going to use in the future. So that's a good thing. But like I said, we'll skip Easter weekend. That'll give y'all time to get it, take a break after this test and catch up with the cardio stuff, and then we'll pick it up the following weekend. But with that being said, as I said earlier, Lindsey will be joining us shortly. She had an SGA meeting. So I'm going to go through the rest of the lectures, and then Lindsey will come on and do some cumulative review questions for your upcoming exam. So I will share my screen. I wanted to show y'all something real quick. If y'all go to the Scrubs page, so we made the YouTube channel private just so it's only SGU students. So if you go to the About section and you use this link, this term one link, it gives you access to the playlist. Okay, so all you need to do is bookmark that link from the Scrubs page, the term one stuff, and you can see this. If you want to get ahead on anything, the reviews we did, we actually started doing these around cardio or end of MSK and cardio. So if you wanted to go ahead and look ahead at some of the cardio reviews we did last term, you're welcome to. But if you just bookmark that link, you'll be able to access it. But that's in the About section on the Scrubs page.
I'm here, Brady.
Oh, all right, awesome, perfect. So we'll go ahead and get started. As you know, I'm on Scrubs. Lindsey is Dog Mom DES. I put some extra stuff, as you know by now, in the Scrubs Drive. Lindsey also has resources on her page as well. So don't forget to look at those extra questions and whatnot. As you know by now, hopefully you've been doing the Grace questions. Those are very representative of how the test is going to be. So if you can get through those, if you can understand the concepts, you'll be good. As for this week, we're going to cover this week 3 material, a lot of histo, a lot of more cellular type of science. So it's not going to be necessarily covered in Grays, but the histo is going to be important. As for the muscle physiology, I know that's more of a twist in the, what you've been learning. Fortunately, it's not super highly tested on the exam, and the test, if I remember correctly, the questions they asked were pretty straightforward. But the concepts of preload and afterload and those things are just precursors to cardio, where it comes in pretty heavily. So that they're just introducing y'all to that right now. So don't stress too much about that. All right, let's start out with, we could go ahead and do a question. You can direct message myself or Lindsey with your answers. Yes, there is a term 2 link for on YouTube as well. So you could say that it's a separate link. So there's a playlist with all the term 1 videos, and there is a playlist with all of the term 1 and term 2 stuff. Yes, we'll go through the VMAX, we'll go through the muscle stuff. Yeah, for sure. We'll do that last. And yes, this recording, I'll get it up later today for sure.
There's a question about the Grays questions. Only do the ones that they assign in Sakai, because those are the ones that are testing concepts that they want you to know. If you go outside of what they assign, you're going into objectives that you haven't gone over yet. So just make sure you stick. There are enough. There are enough that are assigned through Sakai.
All right, so this is just an introduction to healing. We actually are cover this in more detail in term 4. But the thing I want you to notice is that there's no visible scab, right? Once you have an injury, you initially have this clotting formation to stop the bleeding, and then you get scab formation. So if there's no scab remaining, then you know you're far along in the healing process. It doesn't give you a date. Usually that could help you to differentiate if it's a few days out or maybe a week or two, but this is the maturation phase, okay? So there's no scab left. So as we said, inflammatory phase, you get transient vasoconstriction in the area that'll stop the bleeding. Then you get a vasodilation to help bring those factors in, those clotting factors and whatnot. So that's gonna help you with this to bring the factors in to help with the clotting and the inflammation with the white blood cells. But then you're going to start making a scab, and that's going to be the migratory phase, and that's going to be this precursor to the healing process, right? So after that, you get the proliferative phase. This is where you're trying to go back to normal. And lastly, what we're looking at, it was the answer to the question, is the maturation phase. So at this point, this is when we start talking about collagen, and this is just a little introduction. So, but the point I want to make here is that this collagen formation, if obviously you've had, I'm sure most of you have had a scar, you know, at the point where the scab comes off, you get contracture of the scab, of the wound, right? And so this is that maturation phase, that fibrosis, the scar kind of contracts and goes back to normal. So the key thing here is just to point out that there is no more scab left. So we're at the point where you're going back to normal. So this fibrosis phase. All right, so let's get into the more important stuff here. One of the characteristics, so remember, cartilage is type 2 collagen, cartilage, right? That's the way to remember that. So it's type 2. And one of the things that's characteristic when you're looking at this is these isogenous groups. So being able to differentiate where you are in the group is important. So 1 is the capsular matrix, 2 is going to be the territorial, it's kind of between, and then interterritorial is going to be kind of the open spaces. So just be able to identify the different areas. And by all means, if you see these groupings together, whether it's a group of 2 or a group of 4, understand that these are characteristics of this cartilage. So there's 3 different types. I like this slide because it kind of puts them next to each other. Hyaline, they refer to it as this glassy appearance, right? It kind of has this simple structure, but you see these isogenous groups. Elastic cartilage is basically the same thing, except you have these elastic fibers intermixed. And as you can see, they kind of bunch together a little bit more. But understand, and this will help you with the question coming up, you don't necessarily need to use this elastic stain with it, right? So you want to try to identify this versus this, but this doesn't have to actually be this dark stain. And then fibrocartilage is more of a simple structure. It's a stronger structure, and they lay down in these group patterns right here, these linear groupings. So you need to be able to differentiate these and where they show up. So we're going to go through some of the different characteristics of these. So hyaline cartilage is the primary one we think about when we talk about cartilage. It undergoes appositional and interstitial growth. So this is characteristic, and it's also characteristic similarly in bone. So we're going to go through that in a little more detail. So these are characteristics that you need to be able to know in regard to the 3 different types: hyaline, elastic, and fibrocartilage. So appositional growth means you have to have a perichondrium, right? So we'll go through that in a second, right? So by definition, 100%, if you have appositional growth, you have to have a perichondrium because the growth is off of the perichondrium. So we'll get into this in a little more detail when we get to the bone, but for right now, you just need to know that this can grow from the outside, which is considered appositional, off the perichondrium, right? So in bone, it's periosteum. In the cartilage, it's perichondrium. So it does grow out of the sides, but it'll also grow in the middle too. You have this interstitial growth, and there's some differentials that that help you tell the difference. And I have a question coming up, and we'll go into the differences in bone. They have similar characteristics, but different precursors, obviously. All right, and one of the things you need to know is that articular cartilage, the part that kind of fits the bone into the socket, those areas, that it doesn't have a perichondrium, right? So by definition, it can't have appositional growth, okay? And when you think about it, you definitely don't want a perichondrium there, right? Like it fit the bone. This is a great example, the femur into the socket, the acetabulum. So it fits in there perfectly. So you don't want it growing bigger than the socket, right? You want it to fit in correctly as it does. So that's a great characteristics to differentiate the fact that no perichondrium, no appositional growth there. Now, elastic cartilage, we have the same little grouping here as the other slide. So it'll also grow appositionally and interstitially. It does not readily degenerate, and it never calcifies. When you think about the pinna of the ear, right, it never gets hard, right? So you can remember that it doesn't calcify. So again, it's very much like hyaline cartilage, but it has these elastic fibers intermixed in there. Okay, and as I mentioned earlier, fibrocartilage is going to lay down in these rows, right? And notice that the growth here, there is no perichondrium involved in fibrocartilage. So it only grows interstitially. But if you're looking at it here, you could see this linear formation of how the cartilage lays down. Okay, and let's try this one. No, articular cartilage isn't fibrocartilage. They both don't have a perichondrium, but they're not one and the same. All right, so let's look at this one. So this is the trick I was telling you about. If you could see versus the hyaline cartilage, remember hyaline cartilage is going to have that glassed over appearance. Okay, so there's a little bit more groupings of the isogenous groups, but this is actually elastic cartilage. I know it's difficult to appreciate the different elastic fibers. That's why they typically use those elastic stains. But I just wanted to point it out that just because it's a H&E doesn't mean it can't be elastic, right? Yeah, elastic cartilage. So let me just answer the questions real quick. So articular cartilage, yes, it is hyaline cartilage. It just doesn't have a perichondrium. Okay, so it's still considered hyaline cartilage, but we're going to get into the bone in a little bit. And yes, the perichondrium is vascularized. Yes, it does. And that's how the cells reach the surface when you have that growth. All right, and I put this slide in again, right? So just make sure you can differentiate these. All right, try this one. All right, so I just wanted to point out a couple of little caveats just to help you when you answer these questions. So appositional growth, remember we're talking about the perichondrium. So when we look at this, we definitely want to have perichondrium in the answer. But what I wanted to also point out is you need to know that the blasts, all right, the blast build, B and B, blast build in the perichondrium, that's what's going to help with appositional growth. What I want to also point out is on the inside with the isogenous groups, this is actually going to be interstitial growth. So blasts go in the perichondrium with appositional growth, and chondrocytes are going to be deal with interstitial growth. And these are just fully formed cells, right? So just they kind of lay down in the middle, whereas these blasts kind of build the outside of the perichondrium. So however you need to remember that which goes with which type of growth, make sure you can do that. And then this is more of same thing, right? So I had this slide earlier again, so appositional growth versus interstitial growth. There are some factors that come into, especially when you're young, growth hormone that helps with, and testosterone, but I don't think those are too important for you guys right now. So this is a good picture. You could see the osteoblast laying on the outside, right? That's that layer where the perichondrium is. So these blasts are going to lay on the outside and these blasts are going to build. And then remember I said that the osteocytes will be on the inside, and those are going to help with that interstitial growth from the inside. But at the end of the day, you're going to end up having this bone marrow area here. So you have like progenitor cells, which will allow for hematopoiesis or growth of, red blood cells and white blood cells. So that's the primary purpose of the bone marrow in there. So you will have a big cavity, a cavitation in there. But point being, osteoblasts are on the outside. They'll lay down and make fully formed osteocytes. So very similar to the cartilage, right? So we had chondrocytes, or I'm sorry, chondroblasts on the outside, laying down on the perichondrium. Now we have osteoblasts laying down on the periosteum, making osteocytes. Okay, so very similar process. But remember, the osteo goes with bone. All right, so I'll give y'all a second before I'll give y'all the answer, but try to identify, this is bone, okay? You see a blood vessel in there, but try to identify it just in your head or whatever, or yeah, just do it in your head, which cell types these three are. All right, so let's take a look here. If you look, you could see this lining of the bone structure right here. This is fully formed bone, or the osteoid matrix. So you could see this line of osteoblasts on the outside, on the periosteum, right? So they're laying down bone. So what's in this mix here, like you see in the osteoid, these are fully formed osteocytes. So once they become osteocytes, they're kind of stuck in the matrix, right? Or in the calcified osteoid. And if you see here, any of these large cells, these multinucleated cells, these are going to be your osteoclasts. Remember, the blast build and the clasts are going to be responsible for breaking down the bone, right? So blast will put calcium on the bone, and blast will put calcium on the bone, and clast will help reabsorb the calcium and put it back in the bloodstream. So if you have low calcium in your blood, there's hormonal response to help to bring osteoclasts to the bone, and they'll eat away the calcium off the bone to put calcium in the blood. This is not an ideal situation. You don't want to eat calcium off your bone, but if you need it in your bloodstream, the bone has over 99% of your calcium stores. So yeah, so let me just point this out. Osteo is for bone, chondro is for cartilage, okay? So chondroblasts are for cartilage, osteoblasts are for bone. So if you're building cartilage, you're talking about chondro. If you're building bone, you're talking about osteo. All right. I just put this in here for completeness sake. You can go through these and just have a definition for each, and then same thing here. So now let's talk about bone in a little more detail. So there is this form of intramembranous bone formation, not super important. It's kind of intermingled in here. The most important thing you need to remember here is this is where, this is the mode that flat bones form. So typically we talk about long bones, but here we're talking about these flat bones. Flat bones are the skull, the pelvis, things like that. These flat bones will undergo this intramembranous bone formation. Also has a periosteum here, but you see this woven bone formation in the middle. But so remember, remember that this is correlated to flat bones. Well, it may be easier, guys, to just send your questions to Lindsey for the moment, just because it's difficult for me to do all
You
of
can
it.
also send them to the whole group because that actually helps your fellow peers if they can read your questions and they can try to help answer, because peer-to-peer learning is really good too. So send them to everybody.
All right, so this is a really important slide. So this is where we're talking about in the long bones, endochondral bone formation. So the key here is you have to have an epiphyseal plate or a growth plate, right? So until you're about 18 years of age, the growth plate is open. So you're allowed to, well, it allows for growth, particularly growth height-wise, right? The ends of the long bone. So this is very important. And then once you turn about 18, 20, these growth plates close, and that's why you don't grow anymore. So these different zones, you need to be able to identify these on histological slides or questions. So we're going to go through them. So this is the epiphysis is the end of the bone, and the diaphysis is the shaft, right? So what you see here is you have this reserve cartilage, and then as you go towards the shaft, you get proliferation, right? They call this area proliferation, stack of coins appearance, right? If you could see here, you have the stack of coins. Now, after they proliferate, they get larger. Hypertrophy means growth. So the cells get larger, and then they become calcified cartilage. And at that point, the cartilage actually turns into bone, right? Then you get this bone formation. So once the cartilage becomes calcified, you can actually lay it down as bone. So it's important to be able to know this pathway. Remember, it starts at the epiphysis and goes towards the shaft. Okay, and again, the proliferation phase, they like to ask questions about that. That's that stack of coins appearance. And then after that, the cells, they get larger. Okay, so we're going to talk about the periosteum and the endosteum. Remember that if you see like in the previous picture, that pink area, if you see a layer of osteoblast, it's going to have to be on the periosteum. But towards the inside, you get the endosteum. Okay, periosteum's on the outside, the outer circumferential lamellae. All right, by the outside. So this is kind of a cartoon diagram to help us look at some of the bone imaging. So remember that the blood supply comes through these Haversian canals. They are connected through Volkmann's canals, which are the ones that run this way. And these Haversian canals end up with a blood vessel in the middle of these circular areas called osteons. Sometimes it gets tricky. You're able to identify these circular layers here, but there's some that don't form fully. Just understand those were old osteons that were in there, this interstitial lamellae. Those are older osteons, and then as new blood vessels came through, you get newer formation of osteons. So that's what that is. And then so we'll look at some imaging. I think that's pretty much all we can get here. Yeah, let's see. And remember, periosteum, appositional growth, right? Outwards growth. When we talk about, like we talked about previously, this endochondral bone, we're talking about long bone growth, right? This not width, but length. All right, so this is what we want to look at. So remember we said 3 is going to be the middle of the osteon, right? You see the circular osteons. It's just layers of bone come together. Kind of reminds me if you cut a tree in half and you see the different layers of the tree. You can kind of age the tree that way. But it's similar. These bones lay down in different layers and make this circular formation. So 3 is going to be this Haversian canals. You can see them here, anywhere you see in the center of these osteons. The circumferential lamellae, this is going to be towards the outside. Okay, so it's going to come around the osteons. 4 will be this interstitial lamellae. Like I'm pointing out before, these were older osteons, so they don't make this complete circle anymore. And you could kind of see how Volkmann's canal, this is a good cross section of Volkmann's canal. You could see how it kind of feeds into these osteons. Remember, the Haversian canals and Volkmann canals are going to run perpendicular to each other. All right, and if we look a little bit closer, we could see some of the cell types. Remember, this is going to be the Haversian canal. This is going to be the osteon. Here we have this interstitial lamellae that comes around the osteons. 2 is going to be the lacunae. So what happens here is when the osteoblast becomes an osteocyte, it's gonna lay down in this lacunae and it's fully formed. It really doesn't do anything at that point. So this lacunae is just the housing for the osteocyte. You could think of it like that. And what you could appreciate here is you can see the kind of the fibers that allow blood to go from the different osteons, and it's all coming from this this blood supply from the Haversian canal. And yeah, so these little channels are called canaliculi. These are how they communicate. So you can kind of see those there. But remember, these little darker areas are going to be the lacunae where the osteocytes live. All right, let's try this one. The osteocyte is just after the osteoblast kind of lays down the complete osteoid. It lives in there. It's just kind of like a fully formed cell. So there's really no true purpose to it at that point that I'm aware of. Yes, the dark regions in the lacunae, those are the projections of the canaliculi. You could kind of see with the dye that they use how they communicate to each other with particularly blood and nutrients and stuff like that. Let's see. Then the interstitial lamellae, that kind of just surrounds the cell. It kind of just has a protective layer around the osteons, like that outer layer. But blood does flow through there as well. Yes, it is India ink. That is correct. Yeah, that's the dye that they use. All right, let's look at this. Osteogenic protein to promote bone growth and healing. Bone morphogenic protein, or BMP it's called, has been shown to stimulate the differentiation. All right, so what is that going to do? Stimulate differentiation. We're talking about the osteoblast. Remember, these osteoblasts build, so they're going to deposit bone matrix, and once they undergo differentiation, they fully form osteocytes. Then they kind of just live in the lacunae, right? All right, let's try this one. This is more of a clinical application, but yeah, try this. And I will post explanations to, I will post explanations to all of these answers later on with the recording as well. All right, so this is a good teaching point here. Even if you can't diagnose the patient, one of the teaching point here is what's important. So notice the age. I do it. I know a lot of people do it. Sometimes when you're reading these, you gloss over the age, but sometimes it's important, right? So there's a clinical caveat. Maybe the child's really young, or the patient's really old, or there's some sort of window where you want to look. So a lot of times I'll skip over it, not thinking, and I'll get to a point, I'll be like, hold up, let me go back and check the age real quick and see if, just to kind of verify I'm on the right track. So this guy, pain past decade, it would have been better if it was a female for the record, but, and I'll explain why in a second, but let's just go with this. Pain, bony enlargements of the distal interphalangeal joints. So this is not an inflammatory process, but he has these bone spurs in the DIPs. So this is classically osteoarthritis. Osteoarthritis' clinical representation is in the DIPs. You can see rheumatoid arthritis, which is inflammatory, in the PIPs and MCP joints. But if you see it in the DIPs, just know that it's osteoarthritis. So this is the main point I wanted to explain here. Why is this common? Yeah, so rheumatoid arthritis is an inflammatory process. So people have just an overactive immune system, but I don't think y'all need to get into that too much at the moment. Just notice that the DIP is specific for osteoarthritis. So let's see, why is this common in postmenopausal women? Anybody want to give it a shot?
I believe that it's the estrogen usually with premenopausal women that like keeps the osteoclasts from not, I guess, doing their thing. And then with the lack of estrogen, you're going to get this.
Yeah, you're exactly right. So what estrogen actually does is estrogen will act to inhibit the osteoclast. It's a little bit more complicated than that because the osteoblasts have a precursor to tell the osteoclast to work. But so if you saw that in a textbook or something, that's a little bit more advanced than you need to know right now. But for right now, as was stated, this lack of estrogen, so you have no more inhibition of the osteoclast. So just remember that estrogen allows premenopausal women to inhibit the osteoclast, but once you have lack of estrogen, you can't inhibit the osteoclast properly. So that's why postmenopausal women classically are prone to osteoarthritis. Okay, try this one. All right, so this is the same principle here. Like, look how drastic this difference is. So I would say that the patient on the right is postmenopausal, right? So, and you can look at the age here as well. So the pathogenesis, a good habit y'all should get into is when you start getting into these medical terms, make sure you look them up, because as you go along, you could kind of put things together, like osteo is always going to be bone. I don't know if anybody studied Latin. I did not, but prior to going to med school. But as time goes on, you can kind of piece things together by their Latin derivatives. So osteopenia basically means reduced bone density. So in a postmenopausal woman, that's the same principle we talked about before. This lack of estrogen, so overactivation of the osteoclast. Same way of saying is no more inhibition of the osteoclast. All right, so I did mention this is super important. To be able to identify these zones on histological images. So go ahead and try this one. All right, now I put this on here because it is a little difficult. The key, this like, you're gonna come between the idea, is it the zone of proliferation or the zone of hypertrophy, right? Because it's kind of close together. So it's actually this zone of hypertrophy, a lot of words just to ask you which part is the zone of hypertrophy. So that's area 3. So if you can appreciate here, the cells in 3 are a little bit larger than the cells in 2. And remember, I said 2 is going to be that zone of proliferation, that stack of coins appearance, right? So we're starting out here. Yeah, so you see the stack of coins in coins in the zone of proliferation, right? So after that, we go to this zone of hypertrophy where the cells start to get a little bit larger, and then this cartilage will be calcified, and you can lay it down as bone. So we're going to start here. Remember, we start at the end of the bone, and we're going to put cartilage down, and as we get towards the shaft, we're going to lay it down as mature bone. So that's the idea here. Resting cartilage, kind of waiting to see when it's time to go. Then you start proliferating, you get more cells, then hypertrophy, the cells get bigger, and then you can kind of drop them down as fully formed bone. All right, let's do this one. Yeah, absolutely. Zone of proliferation means the cells are mitotically active, for sure. All right, let's take a look at this. All right, again, you know, as you go along, these vignettes will like be more important. For now, it seems like a lot of times they tell you something just to ask you a question at the end, but it's good to get in the habit of reading the whole thing, because as you, like we were saying earlier for CPR, as it gets more clinical based, as we move away from the buzzwords to more practical applications, reading from the beginning will help you to kind of get in the mindset of understanding what's going on, because there'll be little clues here and there. But for now, you could see that it's a lot of words just to ask you what's the most important area in charge of or responsible for longitudinal bone growth. So remember, we're talking about that epiphyseal plate or the growth plate. The answer is B. So these chondrocytes in the proliferation zone of the growth plate. Remember, we looked here, this is the largest area. And you know now that this area is where you're undergoing mitosis, right? So you're growing cells. So this is gonna be the most important area. So they're chondrocytes. Remember, once they're fully formed and they're calcified, they become osteocytes, okay? So at this point, they're still chondrocytes. The chondrocytes are getting bigger, and then we're getting down to both. No, so this is not interstitial growth. This is sorry. This is interstitial. No. Endochondral. Thank you. Endochondral growth. Yeah. So right, because it's coming from the growth plate. Anytime it's coming from the growth plate, it's got to be endochondral. Yep. And you see that here. So right, so we're starting at the end of the bone, going towards the shaft, the calcified cartilage, you see the reserve cartilage, you proliferate, stack of coins, they get bigger, and then you just, you start to calcify them, and these chondrocytes become osteocytes, fully formed bone. All right, we beat that over the head, so y'all are gonna get those right. Yes, the cells do get bigger during hypertrophy, but the proliferation does have a more drastic effect. Like if you look at this is a good example. Look how much larger this zone of proliferation is to the zone of hypertrophy. So classically, just the idea of making cells is going to be more of an indicator of growth. But that's a good question. Oh, try this one. All right, so we're getting into the bone healing process again, but as I mentioned earlier, when we were talking about the wound healing, it's a brief introduction for you guys into this right now. So don't dive too deep into this. So words trying to just basically ask you about this soft callus, right? What are we talking about as the soft callus forms? So you need to know, as a soft callus, it has to form a soft callus before a hard callus, right? Before the proper bone formation. So this soft callus is made up of cartilage and dense connective tissue, right? So it's just that premature formation before you could actually lay down proper bone. So when you have an initial fracture, you have a blood clot formation, and then the soft callus will form here. So this is where we're talking about the cartilage and the dense connective tissue. It's just a faster process. Once this is down, then you could start making the hard callus, right? So you have this soft callus will eventually form a hard callus, right? This bone, and this goes through this interstitial, I believe it's interstitial. Somebody correct me if I'm wrong. Sorry, it's intramembranous. Okay, yeah. So intramembranous, this is the intramembranous process formation. So it'll help you with lay down spongy bone here, which is, so you go from a soft callus where you cartilage and dense connective tissue, then you could lay down spongy bone right on the outside, which is going to be your hard callus, and then finally you get proper bone remodeling, so that spongy bones becomes a compact bone. All right. Yeah, so intramembranous bone formation. That's the process of callus formation.
So the main difference between hard and soft callus is hard has the spongy bone then?
Yeah, right, exactly. So it's just a process, right? You could imagine that this is softer, right? So it's easier to remember once you lay down, once it converts to spongy bone, that's going to be your hard callus. Yeah, for sure. Okay, and then, okay, so once we move into forming this cartilage formation, then it'll undergo endochondral bone formation. Okay, and so, yeah, and then you'll have this primary bone, which is the spongy bone, and it could finally form this compact bone. Yeah. All right. Try this one. Vitamin D is going to be one of those things that comes up again and again. So, so you do find immature bone in the fetus for sure, but I think it is seen in when you're repairing bone as well. All right, so learn vitamin D now. Every term, it's going to come back again and again. So the thing here is the patient is in chronic renal failure. So if you remember that the process of converting it from 25 vitamin D to 125 or active vitamin D, it happens in the kidney. And if you have chronic renal failure, this enzyme 1-hydroxylase, which is in the kidney, may not be active. So you can't convert vitamin D from 25 to 125 vitamin D or calcitriol. And you could see that here. Right, so sometimes when the patient has liver problems, you could have a 25, you can have a problem converting it to 25 vitamin D. But classically, the question they always ask is if a patient has kidney failure, what's the problem? And that's because in the kidney, it's converted to 125 and dihydroxycholecalciferol. So if they talk about renal failure, that's this conversion, because that 1-hydroxylase is the most important enzyme and it is found in the kidney. So let's just break this down real quick. Remember, you use vitamin D primarily to absorb more calcium in the gut. You're going to absorb calcium, you're going to absorb phosphate. So it goes through the process. I don't think we have a slide on that. It goes through the process of bringing in the vitamin D from the gut. Now you also have things like PTH. I don't think y'all got into that yet, but PTH will help to bring calcium from the bone and also bring reabsorb calcium from the kidneys. I don't want to get into too much. I don't know that y'all really got into it yet, but just for now, for this question, just remember that 1-hydroxylase is found in the kidney. So if you have kidney failure, you can't convert it to active vitamin D. Y'all did talk about PTH, parathyroid hormone. Okay, good. So yeah, so if the body senses low calcium, you can secrete PTH. So ideally, the vitamin D is going to bring it in from the gut. But if you need calcium, you can secrete PTH. The first response is PTH is going to tell the kidney to reabsorb more calcium. It's also you're going to urinate out more phosphate. So that's a good thing. You want to keep the calcium. But in dire circumstances, you can actually, PTH will help to upregulate those osteoclasts, so it'll pull the calcium off the bone. Like I said earlier, you don't want that to happen, but if need be, you can do that. So that's that about vitamin D. Yeah, and so they all work together, right? Vitamin D, PTH. Remember, when you have high vitamin D, you're going to bring in calcium and phosphate. The place where calcium and phosphate differ is in the kidney with PTH. The PTH will signal the kidney to bring in calcium, to keep calcium, and to pee out phosphate, okay? I just want to go back. I want to make sure I didn't confuse you guys. So when you have the initial fracture, remember that you're going to have this brief period of intramembranous bone formation by the osteoblast. Once you start to form the callus, you're going to use endochondral bone formation, okay? And then you lay down this spongy or primary bone, right? And then the fully formed or mature bone is also called secondary bone. All right, and that's going to be your compact bone. Okay, let's get into some genetics. I like this a lot better than all that stuff. So genetics is another one of those things. These things will come up again and again, term by term. So the sooner you know them, the better. Try this one. All right, let's take a look at this one. So first off, if you identify the gene, you can tell immediately what it is. So fibroblast growth factor is classic for achondroplasia, right? But let's look at some of the characteristics, right? The father has bow legs, frontal bossing. Ultrasound shows the baby has a short humerus. Okay, so you can see this is classic, and then fibroblast growth factor, as I said, is classic for achondroplasia. Now, this question is hard because trident hand isn't really one of the classic things we talk about with achondroplasia, but what you can try to do is eliminate the other ones, right? So remember we talked about pigeon chest, or this out protrusion of the chest with Marfan syndrome. Yes, I'm not sure. You may see it with rickets as well, but you do see it in Marfan's for sure. Brittle bones, remember that's osteogenesis imperfecta. We'll get into that in a little bit. Cardiac abnormalities, you can see that in Down syndrome, DeGeorge syndrome, and then if you see mental retardation, that could be a number of causes. Trident hand is kind of like this formation, the fingers kind of go like this. But you can see that in the chondroplasia. The fingers kind of veer towards each other. And frontal bossing, no, it's not specific to achondroplasia. There's a number of things. Sometimes the sutures don't close properly. And that can cause, but a number of things will cause frontal bossing. But if you see that, that can be a characteristic of achondroplasia. So this is a thing Dr. Sobring loves to talk about. Gain of function mutation. There are two you should know off the top of your head: Huntington's disease and achondroplasia. What does it mean by gain of function? Well, in Huntington's disease, they characterize it as these choreiform movements, or these dance-like movements that form. Remember, Huntington shows the process of anticipation, right? So it has to do with the trinucleotide repeats at the end of the DNA. The more you have, the sooner the onset of the disease. So if the father has 200 of these trinucleotide repeats and he got it at 50 years of age, and the son will have more, and so let's say the son has 250 of these trinucleotide repeats, he may have it in his mid-40s. So you have a gain of function, you develop these dance-like or these choreiform movements. So that's classic for Huntington's disease. As for achondroplasia, the gain of function, that kind of seems backwards because they tend to be short. But for achondroplasia, the gain of function is they gain the ability to close the epiphyseal plates. They gain the ability to close those growth plates. And because they close the growth plates so early, that's why they don't tend to grow. That also leads to the frontal bossing as well. All right, try this one. All right, let's take a look at this one. It's good time as any to point out some of the things. I personally use a good bit of the features on ExamSolve. Every time I take a test, it's exactly the same. I use the highlight feature as I read through it. It helps me to slow down, because sometimes I'll read a whole question and I'll be like, I don't even know what I was reading, right? So by highlighting it, it helps me slow down, pick out the important words. And then when I go back and check the exam, I could kind of just look at the important words and see where I was at. So that's a good habit to get into. Highlight things like this gene, bone fragility, short stature, stuff like that as you go along. Also, the scratch out, the strikeout feature is really important too, because there's a psychological component to actually being able to look at just two answers. So get into a process of repetition. You should do the questions the same every time. It'll be less stressful. Flag the questions you don't know, mark the best answer you have, but flag it. That way you can come back and check it later. But the more of a routine you can get in, the less stress you'll have going into the exam. So try to do that. Just a bit of advice. So the COLA1A gene, that's important. Classically, that's osteogenesis imperfecta. If you weren't totally sure that was that, you could see bone fragility, and that's classic for it as well. So what you actually see with OI is they get short limbs. But again, this isn't one of the super standout one of the super standout symptoms that you see, like bone fragility, of course. Also, that's a good point to bring up. a lot of times, and they'll put this in the question, the doctor suspects child abuse. That's because when they go and get the x-ray, you can see multiple fractures that are healing at different times. So it does look like there's some semblance of child abuse. So they typically they do mention that in the STEM. So that's classic for OI as well. Thank you for pointing that out. Yeah, so we have short limbs. So osteogenesis imperfecta. What are the things that are a little bit more common? Blue sclera right away. You know that's osteogenesis imperfecta. You could see hearing loss and short stature as well, a respiratory problem and some tooth development. But if you see blue sclera, bone fragility, stuff like that, you're thinking of OI. I have the other ones here as well. Pigeon chest again, Marfan syndrome. Yellow sclera is classic for liver disease with bilirubin. Y'all will get into that later. And ruptured aorta. It probably does happen in Ehlers-Danlos, but classically, as they teach it, Marfan syndrome. This is why it's recommended that kids that have Marfan syndrome don't actually play sports. If y'all know the story of the basketball player from Baylor, he was 7 feet tall, he was drafted into the NBA. He had a subluxated lens, right, which is classic for Marfan's. But until he was in his 20s, he was never diagnosed. Well, the NBA diagnosed him, and he didn't get the multi-million-dollar contract because he was diagnosed with Marfan syndrome. But if you guys saw him on TV, you would be like, that guy has Marfan's. So it's like, it's crazy that he was never diagnosed as a child, but it's a good story. He played at Baylor. You could look that up. Okay, let's try this one. A little bit more difficult here. All right, so let's take a look here. Again, we're looking at the COLA-A1 gene. So we're looking at osteogenesis imperfecta, point mutation, bone fragility, right? So same situation here. So the key here is there's a point mutation. So now we're differentiating between the different types of OI. So with the point mutation, you're looking at a dominant negative. That's the formation. So we're going to get into this in a second. So the idea is with haploinsufficiency, you have a decreased amount of a normal structure, right? With dominant negative, you have some normal structure and some abnormal structure, and the abnormal structure affects the normal structure. So in relation to this, right? So osteogenesis imperfecta, it's better to have less of something normal than more of something abnormal. This is why OI type 2 is worse, right? So again, even though haploinsufficiency, you're not making as much bony product, you still have some normal bony product. But as for the dominant negative, some of it's normal, some of it's not. You have a lot of it, but there's a lot of abnormalities built within it. So that's why this is much worse, because the bones are much more fragile. So, and you could see that here, this is a good slide for it. You could see that this haploinsufficiency, that's classic with the blue sclera, and typically OI type 2 is lethal in the womb. So remember, point mutation is going to be type 2. That's the worst one. And then you could see the allelic or the haploinsufficiency here, and that's classic for OI type 2. All right, and you can see this is kind of what I was talking about here. This missense mutation will lead to an abnormal formation, whereas the nonsense, I think I have one. Is this the nonsense? Yeah, so the missense mutation, you'll get abnormal, enough product, but it's gonna be abnormal. So that's very severe. Again, it's better to have less of a good structure than more of a bad structure, right? So this is why this is worse, because you see the green here is intermixed, and it's all of the bone is very fragile. Whereas if you look here, this haploinsufficiency, you're making proper bony product, you just have less of it. So again, the bones are fragile, but at least you have some normal bone going on, right? With the more severe form, type 2, you have no normal bone. It's all messed up, okay? So, and this is another thing, because, you know, if you look here, depending on if it's an enzyme versus a protein, right? These are classic for, well, what are we talking about with this genetic mutation? Is it some sort of enzymatic problem, or does it lead to some sort of structural problem? So you can't just necessarily say that a missense is worse than a nonsense or vice versa. When it comes to enzymes, nonsense mutations are worse because it's cutting the enzyme that you're making to a smaller product. So it's just not functional, right? So that tends to be worse. Whereas a missense mutation for something like collagen, like we were talking about in osteogenesis imperfecta, these tend to be worse because it's more of a structural problem. With missense, you're not getting any proper structure. At least with nonsense, you're building some of a normal product. So this is just a little more advanced, but if you're interested, it kind of just points out that you can't necessarily say one is worse than the other. You have to differentiate by what you're looking at, an enzyme or a protein, or enzyme versus structure. All right, try this one. Yeah, sorry, type 1 osteogenesis imperfecta is a nonsense mutation. So it's cutting it short. That's why it's haploinsufficiency. Versus type 2, which is a missense mutation. Yes, point mutations can lead to a missense or a nonsense mutation, depending on if that point mutation causes a stop codon. If it causes a stop codon, then of course it's going to be a nonsense. But if it just changes the amino acid structure, then it's going to be a missense. So yeah, it just depends. I think there are different types of OI, but those are the only two you need to know for right now. All right, so let's take a look at this one. Muscular disease, so I would highlight that. See the maternal uncle, so we know there's a genetic thing. He has difficulty standing, okay, from seated. That kind of sounds familiar, and it's muscular. Bends forward, using his hands to help push up from the floor. Does anybody know what this is called?
Gower sign.
Yeah, right, exactly. So that just means that your hip, your girdle muscles aren't very strong. So you have to use your upper body to stand up. Yeah. So the Gower sign or Gower's maneuver. Yeah, exactly. So, and then he straightens his knees to stand. So you suspect muscular dystrophy. So first off, then it says, what is the most severe type of muscular dystrophy? So there's two we talk about. It is Duchenne's muscular dystrophy and Becker's muscular dystrophy. For Duchenne, which is the worst, you get a frame shift mutation. Anytime you get a frame shift mutation, you got to think it's bad because you're shifting the reading frame, right? So the amino acid is going to read every three, or the protein that's laid down is going to read every three bases for the codon. So if you shift the frame, all of the amino acids that are laid down after that are going to be wrong, right? Because you're shifting the reading frame over. So understand that a frame shift mutation is classically just the worst. So what you see in Duchenne muscular dystrophy, because of this frame shift mutation, is almost a complete absence of dystrophin. You read different books or whatever, some of them say complete absence, some of them say just a little bit, but for what you need to know, it's just, you can consider it a complete absence. Now, what you'll see with Becker's muscular dystrophy, it's an in-frame deletion. So right away, you know that this will tend to be okay, not okay, but better than Duchenne's muscular dystrophy. So because it's in frame, okay? So you have a reduced amount, but with Duchenne's, it's almost a complete absence of it. So sadly, with Duchenne's, a lot of times these children are wheelchair bound by 12. They usually pass away by their 20s. Their reproductive fitness, their ability to have children is zero classically. And Becker's, they do have a higher reproductive fitness. So what that tells you is that if these people with Duchenne's muscular dystrophy have a reproductive fitness near zero or at zero, then this disease that's formed, this genetic disease, is rarely passed along, right? It's usually something that happens innately, because how do you pass it along if the people that get these diseases aren't having children? So just another caveat there as well. So if you look at these, you could see here, this is a normal patient. So it's a biopsy of the muscle, and you could see this dystrophin, these proteins that form in the muscle. With here, you see a decreased amount. So you'd say this is an in-frame deletion, classically Becker's. And you see here, this is none or little of the dystrophin protein. So this would be Duchenne's, which is the worst, right? Frame shift mutation. All right. So I know Dr. Sobrin gave you all that long DLA. I'm going to point out the important points of it. So let's try this question. It's not as bad as the DLA made it out to be. All right, let's take a look. So 18, prescribed codeine, okay. And then he starts experience adverse effects, probably respiratory distress or hypopnea, right? He starts having trouble breathing or breathing very slowly. So this guy is an ultra rapid metabolizer. So first, let me point this out. You never want to give codeine to children, and that's because classically children are ultra rapid metabolizers. So they're going to convert this codeine into morphine more quickly. So let's talk about this. These CYPs are your liver enzymes that help to metabolize drugs, right? So they go through this process. This first pass, they hit the liver, they kind of activate them. Second pass, they hit the liver, they kind of inactivate them through the bloodstream. So some drugs, when you take them, they're inactive. And then the first pass, when they hit the liver will convert them to the active form. That's what we're looking at here. Codeine is a good example of that. You take codeine, it's inactive, it hits the liver, and it's converted to morphine, okay? So if you're an ultra rapid metabolizer, you are gonna take that inactive codeine and you're gonna convert it to morphine very quickly, which means you could end up having toxic levels of morphine in the blood, right? So that's classic for codeine. I think metoprolol was the other one that they gave you. So let's talk about this. Metoprolol, when you take it, it's already active. Okay, so when it hits the liver, it will inactivate it. So you can get increased levels of metoprolol if you are a poor metabolizer, right? So that means the drug is active in your system, and if you don't metabolize it quickly enough, there's going to be too much active form in your body, right? Because you're not metabolizing it fast enough. So the initial metoprolol you take is already active. So when you go to metabolize it, you're a poor metabolizer, so you end up with increased levels. So be able to differentiate codeine, which is inactive. Ultra rapid metabolizers will convert it to morphine quickly. That could be toxic. Whereas metoprolol is already active. So if you're a poor metabolizer, you're going to keep too much of the active form in your body without inactivating it. So a good example, this is a good test question because this is very clinically relevant. I don't think I have a question on, okay, I don't, so let's go through this. Okay, so the ranitidine receptor mutation is classic for malignant hyperthermia. Okay, so they talk about succinylcholine and what's the other one?
Halothane.
Halothane, yes. So when they give it to patients for anesthesia, some people which have these ranitidine receptor mutations will have a reaction to the halothane or succinylcholine that'll cause malignant hyperthermia. So what do you need to know about this? This process, this ranitidine receptor will be tonically open. So you get a huge flush of calcium into the cell when you have this malignant hyperthermia. So the patient will be tonically contracted. Their muscles will literally lock up if they get this, if they react to this succinylcholine or halothane, right? So that's what's going on. This receptor, so they get malignant hyperthermia. So I'm not sure if they pointed out the antidote for this is dantrolene. So if they put that in your notes, make sure you know that as well. So some of the buzzwords: ranitidine receptor, succinylcholine, halothane can lead to malignant hyperthermia. The reason they get so hot is because they're burning ATP, right? They're just tonically contracted, so it leads to hyperthermia. There was a few slides on this polymorphism. It can lead to myelosuppression if you're treating somebody with thiopurine drugs like leukemia. Again, just a general understanding of this and you'll be fine. But this is this polymorphism that leads to aplastic anemia and stuff like that. Fragile X, I think we're going to go into that in a second. So this kind of talks about codeine converted to morphine, metoprolol being inactivated. CYP2D6 is not the main CYP enzyme, or they're classically called CYP450s, but it's one of the important ones. So it's going to convert this. So just most importantly, remember the codeine morphine conversion. And then ultra rapid metabolizers, that's when we're worried about converting too much codeine too quickly to morphine. All right, try this one. Oh, have y'all not? So if you can at least diagnose this patient, that'd be fine. And I'll just point out, I think there was one slide that talked about so quickly, let's go back to the last one. It was mentioned in the chat. Let's talk about the dosing regimen. So if you know someone is an ultra rapid metabolizer, when you give them codeine, you want to give them a lower dose, right? Because if they're an ultra rapid metabolizer, you don't want them to get to toxic levels when they metabolize it. Same thing with metoprolol. If they're a poor metabolizer, you want to give them a lower dose because they're not going to metabolize that active metoprolol fast enough. So let's look at this. So yeah, this guy, look, he's got patient state's father who died at 50. He's 31. That's that anticipation process. So classically in Huntington's, they do show depression as well. But let's see. Similar condition, yeah, sudden, jerky, purposeless movements. That's that choreiform movement. So this guy has Huntington's. So classically, the caudate nucleus is what degenerates in Huntington's disease. I think this was the slide this was from our notes. So if they took it out in yours, don't worry about it. But this is kind of the location of where the caudate nucleus should be. But you get atrophy of that area on both sides, and that leads to that bilateral a degeneration or atrophy. Good question. How do you know if someone is a fast or slow metabolizer? Traditionally, you just find out by by medication and seeing how they react to it. There are genetic testing out now that you can get. You can send off kind of like 23andMe, and they could tell you how active your CYP450s are to see. And a lot of times they prescribe stuff like, oh, I forget what it's called. They prescribe like a folate analog to help isolate or maintain your levels of your CYP. It helps with that. But yeah, traditionally you just kind of give the patient medication and see how they react to it. So it is a little different. Okay, I would put a star on this slide. In regards to the trinucleotide repeats, you need to pretty much know everything on this slide. So a few things. This is our start codon, this is our stop codon. So you see Fragile X syndromes, the CGG, oh, I forgot what the, there's a good mnemonic in protruding chin and giant gonads, I think it's in first aid, but you can go look at these. I think they have it. I think that's why I remember it, because it's so ridiculous. So it's CGG, that's for Fragile X syndrome. So you need to know it's before the start codon in the 5' untranslated region. So you get this epigenetic silencing, okay? And when we talk about methylation of a gene, that's when we talk about silencing. Remember, we talked about that heterochromatin formation, that methylation. Friedreich's ataxia is gonna happen in the coding region, okay? It is an intron, it leads to heterochromatin and reduced gene expression, autosomal recessive. You can also see Huntington's disease, remember that's CAG, and this is also going to be a gain of function, remember achondroplasia and Huntington, and this is going to be autosomal dominant. Remember this CAG codes for glutamate. So when they talk about, glutamine, when they talk about this polyglutamine amino acid tract, that just means there's a bunch of CAG repeats in a row. So you get a bunch of glutamines, right? It's when the amino acids come in. So that's what they talk about with this polyglutamine. And then after the stop codon, we have myotonic dystrophy. So it'll be in the 3' untranslated region, autosomal dominant, and you could kind of read about this. But I would definitely know these to be able to differentiate these, especially the locations. And if you know what the codons are for them, you know, those are just easy tricks on the test to be able to figure these out. I think, oh, nope, we got to do muscle physiology. I thought we were done. Now the good stuff. All right, try this question. We could take a break. Let's get this done and we'll take a break before Lindsey does her questions. Yeah, this isn't too bad. All right, so a little tricky here, and that's why I put this on here. So maybe they don't even tell you that the patient has myasthenia gravis. Maybe she comes in complaining she gets weakness as the day goes on. She gets ptosis, or like her eyelid starts to droop as the day. Classically, myasthenia gravis patients get worse as the day goes on, okay? Worse with repetitive movement. And that's because these acetylcholine postsynaptic receptors get bound up by the autoantibodies that these patients are forming. So they have few receptors for the acetylcholine to bind at the neuromuscular junction. So with repeated movement, you're binding the acetylcholine to these receptors, and as you keep moving, there's not enough receptors to be bound because of the autoantibodies. So you do give these patients acetylcholinesterase inhibitors. If y'all remember from FTM, this will help to increase the acetylcholine in the synaptic cleft and that will allow for more available acetylcholine to bind, right? So this tends to help them. It's not a perfect kind of medication, but it does help. So the acetylcholine to these nicotinic receptors has to be signaled by something. So that's why I wanted to put this in here. It is signaled by sodium, which is what you would expect. If you have an impulse down, an action potential, you would expect sodium to signal the acetylcholine to be released. Okay, you can kind of see this here. We're dealing with the nicotinic cholinergic receptors here, this NM receptor, and you could see those there. Let's see. All right, try this one. All right, so you see here a black spider bite, right? So she has cramping, muscle pain. So what you're actually doing is with this letrodotoxin is you're increasing the presynaptic calcium concentration. So this will lead to an excess in acetylcholine release because calcium is going to stimulate muscle contraction. So then the acetylcholine is released, and that's why you're getting these cramping and muscle pains. So you should be able to identify that this is letrodotoxin. And you can see that here, this presynaptic calcium voltage gated channels is increased, which will lead to excess acetylcholine release and binding, which will cause the symptoms. And this is very similar to Lambert-Eaton syndrome. You should identify that myasthenia gravis is almost opposite. Well, it is pretty much opposite of myasthenia gravis, right? Lambert-Eaton syndrome, they get their muscles, they get stronger with contraction. And whereas the myasthenia gravis patients, they get weaker with repetitive muscle movement. And the reason that Lambert-Eaton syndrome, they get stronger is because they release just small amounts of calcium at a time. So the more you're able to have this repetitive movements, the more calcium can be released, and that will increase the ability for the muscle to contract. So just know that they're kind of opposites. They're both caused by autoantibodies, but they end up having different sorts of symptoms. All right, let's take a look at this one. Yes, Lambert-Eaton syndrome is presynaptic. These autoantibodies, and myasthenia gravis is postsynaptic acetylcholine receptors. All right, so which curve is produced when a muscle is at its shortest length? So what we're talking about is the preload. So think about it if you're lifting weights, right? If you're doing curls, the shortest length is going to be your shortest preload. Okay, so this is why the answer is 1. And this load you're putting on is your preload. Now, again, as I mentioned earlier, this is very much introductory to what y'all are going to about to do in cardio. Preload and afterload is very important for the heart. So this is just a general introduction to it. It's not super high yield on the exam. But what you'll see is these this preload. This is a light weight. This may be like a 10-pound weight, whereas 5 may be like a 50-pound weight, right? So the more preload you have, the more stretch you're going to have on the muscle fiber. That's all they're trying to say here. So if you're lifting light weight, you're not really stretching the muscle fiber out as much as if you were lifting heavy weights. So that's why we're looking at that here. That's all they're really saying here. So force or load or afterload is the amount of weight you're putting on the muscle, right? And then the Vmax is going to be how long it takes to get to its goal or its maximal contraction. So obviously, the less weight you have, the easier or the faster the velocity to get to the point, right? If you're lifting light weights, you're gonna reach Vmax faster, whereas heavy weights are gonna take a longer. So that's that force velocity curve. It's gonna take, if it's less weight, the velocity is gonna be faster, right? More weight, it's gonna take more time. And just to point out, isometric is the force it takes for your muscle to contract before you start lifting the weight. Okay, so it's a contraction of the muscle, but once you start actually lifting the weight up, then it's isotonic. Okay, so metric is just when it's static, right? You have to actually contract the muscles to get ready to start pulling the weight up. But once you start pulling the weight up, it's isotonic contraction, right? Tonic meaning the same amount of weight, right? So metric is the same amount of length, as in you're not changing the length of the fibers, but once it's isotonic is the same amount of weight. So that's just a differentiation for isometric versus isotonic. Just remember, metric is static, you're not moving, and tonic is the actual contraction of it. All right, let's try this one. Yes, I'll post this. We'll get it recorded and post it for you guys. It'll be posted later on today. Yeah, that's a good point. So you could think of it like that. So the highest velocity is from the smallest weight, and that's why on the graph you see it with the steepest slope. Yeah, that's exactly right. So as long as you can identify those graphs, you should be good to go. All right, which of the following does not change its length compared to when the muscle is at rest? That's our A band. And when we look at it, A band is the length of the thick fiber, right? So let's take a look at this. You see this A band, this is the thick fiber. So as this muscle contracts, you'll see that the thin fiber overlays the thick fiber. So the A band isn't going to change. Now, the I band represents the amount of just thin filaments, okay? So as it starts to overlay, this I band is going to get shorter. So the way I like to think of it is the I band is from the end of one thick fiber to the beginning of the other thick fiber, or the amount of just thin filament. Okay, so the I band is going to contract. The H band is from the ends of the thin filament. So as the thin filament overlays the thick filament, the H band is going to get a little bit smaller as well. Remember, this is the M line and the Z lines are at the end. It is important, you should know these proteins, this titin protein amongst the other ones that come up in regards to like the Z line and connecting and stuff. All right, try this one. Yeah, as for the muscle physio, you'll probably have a few questions on it. I would know the graphs for sure, the ones we just went over. As for the clinical presentations, yeah, like for sure, for Lambert-Eaton syndrome, myasthenia gravis, you definitely want to be able to differentiate those. All right, so straightforward question here. Remember, smooth muscle is gonna have calcium, and calcium always is gonna bind to calmodulin. So when you differentiate smooth muscle from cardiac and skeletal muscle, or smooth muscle from the striated muscle, it's a different process. The thing about smooth muscle is you want it to be tonically contracted a lot, right? So this is the process that goes about doing that. Whereas your heart's you want to be able to contract and relax, and your muscles, your skeletal muscles, you contract and relax. A lot of time your GI system, a lot of the smooth muscles are always contracted. So you want to be able to hold them in this contracted state without really, fatiguing the system. So this is how you do it. You use calcium, binds to calmodulin. It activates myosin light chain kinase. Kinases always phosphorylate. Y'all will get into that in DM, but kinases will phosphorylate. And this will put the muscle, the smooth muscle, in this process or this state of contraction. And it'll just hold it there until it needs to be released. So just make sure you know that this is a different, this is a different process than striated muscle. So some of these words are going to be specific: myosin light chain kinase, calmodulin. These are all very specific for smooth muscles. All right, let's try this one. Yes, Lillian, that's right. Yeah, in the chat. Right. So of course that the smooth muscle isn't going to have troponin, so it has to use the calcium calmodulin complex. You are correct. All right, another, this is a difficult question, but I wanted to point this out. By no means do you want your heart to be tonically contracted, right? You don't want tetany of the heart. Like sometimes your skeletal muscle can lock up, which is not good, but you definitely don't want the heart to lock up in a contracted state, right? So the idea here is that you have a delay in action potentials that allows the heart to have to stop and be able to start again. So there's not an overlap in action potentials. What you could see is with muscular contraction, like skeletal muscle, sometimes these action potentials can overlap and it allows them to be tonically contracted. So, but with these, with the heart fibers, you have this pause between action potentials, and that allows time for the heart to relax, to fill, and then contract again to be able to pump blood out. And this kind of just goes in, maybe put a star on this slide, just to kind of differentiate the two. Obviously, skeletal and cardiac is both striated, so it has a lot of the same properties. Remember, if you have to identify cardiac, it's a branching pattern on histology. And then again, smooth muscle is a different sort of system, right? So you use the myosin light chain kinase and stuff like that. So definitely know that. I think this may be my last question. Go ahead and try this one. Awesome. Yeah, you got this. So rigor or rigor mortis happens post-mortem after death. So what actually happens? Well, after you die, you don't have ATP, right? So this decrease in ATP makes that complex, which you should know, the myosin heads and how ATP has to with the power stroke when ATP changes to ADP, and then when ATP binds the myosin head is removed. So there's a little chart in your notes. There should be, it's a little circular chart, which kind of shows the process, but just know where ATP is involved, know where ADP is involved, and how that power stroke works to contract the muscle. But here again, when you don't have ATP, you'll have the power stroke, and then the ADP is locked in that format. So that's how you get rigor mortis. You don't have ATP to unlock the power stroke or the myosin head. This was just a little DLA. It wasn't super important, but I just wanted to put it in here. Phosphorylcreatine or creatine phosphate is classically, if you work out, a lot of people take creatine supplements. It is an energy form for the muscle. It does have more energy per molecule than ATP, but obviously, you know, now you primarily use ATP as your energy source. But there are high energy molecules that you can use, and phosphorylcreatine is one of those, primarily in the muscle. All right, so what we'll do here is we'll take a 5-minute break. We can answer some questions for you guys. We'll come back and Lindsey's got some cumulative questions for your exam.
This is what I want. Okay, just a reminder, just private message in the Zoom chat your answers to Brady and or myself. I'm gonna give you guys about 30 to 45 seconds per each. If I see that there's a lot of good responses, I'll just advance the question. Okay, so first one. So a 53-year-old woman presents for a follow-up 6 weeks status post MVC, so motor vehicle collision, in which she sustained multiple traumatic fractures of her pelvis and lower limbs. She has been attending physical therapy, but has some difficulty walking. She has positive Trendelenburg on the right, which nerve is likely compromised. Okay, we're getting a mix of answers, but most of you guys are getting this correct. It is the right superior gluteal nerve. If you have a positive Trendelenburg on the right, that's where you are going to find the lesion, because you're going to have that hip drop thing when you're standing on it. Just think about all of the muscles in your hips and thighs are allowing normal gait to walk forward. And so when one extremity is engaged, the other extremity also has to be engaged to make sure that you can be stable when walking. So when you have a positive Trendelenburg, that standing on one leg, that means there is a disconnect between the stabilization. So it's right superior gluteal. Okay, most of you guys are getting this correct. It is a trunk. You guys have a lot of questions about the Trendelenburg one. I am going to go back to my notes to make sure I keyed that correctly. Which was it on?
Yeah, that's right. So
Yeah.
the girdle muscles on the right side will hold the left hip up, right?
Yeah.
So if you have weakened muscles on the right side and you lift the left leg up, the left hip's going to drop because those right girdle muscles in the pelvis are going to help it. So it is opposite. Same thing for the other side. If you have weakened left gluteal muscles, when you pick up the right leg, the right hip is going to fall. It's the job of the opposite gluteal muscles to help keep the lift stable, parallel.
Okay, so a lot of you want me to explain this question. I am going to explain this question. So when you're talking about the brachial plexus, you have the levels, right? So you have the roots, trunks, division, cores, branch. There's a remember to drink cold beer. That's the one that I have, the acronym that I have. Remember to drink cold beer. So if you look at this, these are your roots, and then you get your trunks, which is this area. Then you have another division. These are the division. These are the cords. And oh, I need the, go back up. Is there a laser pointer on here? Where's my stylus? Come on. Oh, don't do this to me. Okay, my computer's messing up. Hold on. I just disconnected it from my monitors. I'm hoping that'll fix my issue. Okay. Roots, trunks, divisions, cords, branches. So when we're talking about where this is coming off, the question stem said that the person cannot initiate abduction. So, you know, there are 3 muscles involved in abduction of the arm. The first one is going to initiate, that's 0 to 15, that's suprascapular. Then 15 to 90 is deltoid, and then you have above 90 degrees. So if he cannot initiate abduction, you're talking about supraspinous, suprascapular. And so you have to know that this comes off a trunk. So it is just as important to know the individual nerves coming off of the brachial plexus and where they come off as it is to know the names of them, unfortunately. So make sure that you are aware of that. Okay. Does everybody understand that, how we got the answer to that question? So I'll go back to the gonna stop annotating. I'm having a lot of problems with my monitor system, guys. I apologize. It's not letting me. What did I just do? Okay. I think I need to restart my computer, honestly. It is not cooperating with me right now. And so I'm going to sign off, ask Brady any questions, and I will be back in about 2 minutes.
Not any questions, but pertinent questions to what we're doing.
Yes, pertinent questions.
No worries, Lindsay. Yeah, that's fine.
It did this during my SGA meeting this morning, and so I apologize. I'll be right back. Okay, so does anyone have any questions about this question before we move on? I know this is where my computer started to flip out. Okay, I'm not getting any responses, so I'm going to go ahead and move on. But just know that with respect to the brachial plexus, you do need to understand the difference between branches, trunks, divisions, roots, all of that stuff. The good thing is there aren't very many small branches that they name for you that come off. And so just know the ones that they give you and you should be fine. Yeah, pretty much all of you guys are getting this right. It's L4. And so it's going to be the one that it's under. So remember the cervical versus thoracic versus lumbar. If you have a compression or if you have a herniation, which nerve is going to be affected? And remember, cervical has 8 nerves and only 7 vertebrae. Childhood ED with severe right lower extremity pain. Yeah, there's pretty much 100% consensus on this. I don't see any deviation, so you're all getting it right. It's B, opening of the presynaptic calcium channels leading to excess synaptic acetylcholine. So I'm pretty sure Brady talked about this. Remember, this is presynaptic, so you do need pre versus post. But in this exam, for your purposes, you're only going to have 1 to 2 questions on this over these different toxins. So sorry, this is kind of blurry, but this is just showing that fact. Yeah, make sure that you guys are reading these very carefully, especially with MSK. It's very important that you understand exactly what they're talking about because a lot of these nerves, a lot of these actions are going to be very similar. So the addition of a certain word can change your answer choice. So just make sure you're reading it very carefully. And the muscle actions too, you know, the abduction of the arm, it's initiation versus the rest of them. Okay, there's kind of a mix. There's a real big spread here, which is fine. So the answer is actually ilioinguinal. So make sure that you do go, I don't have a picture accompanying this, but do make sure that you understand the cutaneous innervation of all of these. Some of these have motor innervation. So make sure that you can distinguish between those two. I think there's only 2 or 3 slides in your lecture notes, but it is a very, very, very high yield 2 to 3 slides in your notes. You can get a handful of questions from here. The lecture from the previous question, I believe, it's one of the first pelvis and perineum ones. I organized my notes by region of the body, and so it's one of the first pelvis and perineum ones, I believe. So we're kind of between 2 answers here. That's okay. So the correct is calcification of the bone matrix in the matrix. The biggest thing here is going to be the he's not receiving the supplementation of vitamin D, and vitamin D is going to allow for that entire process of the calcification. So bone resorption would be if we have low calcium, and so you would get bone resorption to put calcium back into the serum to increase serum levels of calcium. But calcification of the bone matrix is the biggest one. That's from pre-test. This is a question straight out of pre-test. I thought was really good for you guys. Pre-test is a question book. It's just a set of questions. If you reach out to me, I can help you find that. Okay, most of us are getting the correct answer here. The biggest thing you need to do, step one, is identify the degree of the burn, which is what? You can put in the chat. Yeah, most of you are getting this right. It's a 3rd degree burn because you're seeing charring of the area. 1st degree burn, it's like a light sunburn. 2nd degree, you are going to get blistering. 3rd degree is differentiated because you have charring of the area, you have swelling and fluid drainage. This means that you are involving the deeper area, so it's going to be D, and this is going into the hypodermis. And so charring is a really big word there that's going to point you towards a 3rd degree burn. Right upper extremity, RUE, right upper extremity. Next one. This is one that you might have 2 or so questions on it, and I hope everybody can get 100% on this. Oh, I didn't convert this into ABCD. I apologize. I'll do that before I send it out. But all of you guys are getting it right. It's the annular ligament. So this isn't actually a bad injury if there's no fracture involved. This just holds that the bone in that joint, and it can slip out really easily. So playfully swinging, or another example is a child that's running into traffic and the mom pulls the child back. That's another, but it's called a nursemaid's elbow. So it's a really easy reduction. You just pop it back in. Usually a doctor can do it on initial patient contact. And so you just get to pop it back in really quickly. Yeah, all of you guys are getting it correctly. It's the ryanodine receptor. So if you have a mutation in this receptor, you can get malignant hyperthermia. They love this question, and USMLE loves this topic of malignant hyperthermia. But this is the corresponding slide. Dantrolene is the treatment for it. They'll most likely test, they can test you on either. They can diagnose the patient for you and ask you how to treat it, or they can do it the other way like I did it. But make sure you know what it is for that. Dantrolene was the treatment. Association with the DHPR. I don't remember what that is. Okay, There's kind of a spread on here, which is fine. You guys know the name of the nerve. It's the lateral antecubital brachial oh my god, I can't talk. But it's the lateral cord of the brachial plexus. And I admit I tried to make this a little difficult for you guys because everyone remembers the musculocutaneous nerve, radial, ulnar, and all of that stuff. I tried to make this difficult, so you know you need to look at that brachial plexus in a little more detail. But the lateral cord of the brachial plexus is the directly gives rise to the musculocutaneous nerve. And within the musculocutaneous nerve, you have the lateral antebrachial cutaneous nerve, which supplies lateral cutaneous sensation to the forearm. So you will have some that are a little more straightforward, and it's not going to ask you stuff like this, but I did want to make it a little trickier for you guys, so you just are aware that they can pull that on you on the exam. Yeah, all of you guys are getting this question right. I'm going to let a few of you punch in before I reveal the answer. Yeah, pretty much everybody recognizes this as a mid-shaft fracture. Mid-shaft fracture. So how do you get that? So you have wrist and hand involvement, so you know the injury can't be close to the wrist. It has to be farther up the arm. And we told you it was a humerus fracture. And so the mid-shaft is where you're going to get, which nerve are we talking about? Yeah, we're talking about the radial nerve. And so step one, identify what the injury is. Step two, we are going to get the radial, step two, you have to figure out, I just forgot what I said, but figure out the nerve. So you know you can't make a fist and child cannot extend the wrist. So that's wrist drop right there. Child cannot extend the wrist. That's another way of saying wrist drop. So you know it's radial nerve if you're talking about wrist drop. And so mid shaft of the humerus. Why is it not supracondylar fracture? Does anybody have an idea?
Isn't the supracondylar for the median nerve?
Yeah, it's for the median nerve. So make sure that you guys know the nerve that's associated with all of these. This is very high yield, and if you can get used to all of these presentations, you'll get a handful of questions right on the exam. Yeah, you guys are absolutely correct. The anatomic neck is just a name of part of the bone. It's just in there as a distractor, honestly. Most of you guys are getting this correct. Some of you are switching it up with the other one that they told you. But you're going between the two, so I like that. You understand. So which disease is this one? First, you can put it in the chat. Bullous pemphigoid, right. And so you can tell the difference between bullous pemphigoid and pemphigoid the vulgaris one by the presentation of the blisters. And this one says the blisters are taut and don't easily break. The way I remember this is because bulls are tough and these blisters are tough and they don't easily break. The vulgaris one, they shear very easily when you rub your hands across them. What's that sign called? Nikolsky sign is when it's a very easy rupture of those vessels. And so for this one, it's the hemidesmosomes. The hemidesmosomes are going to attach the stratum basale to the basement membrane, and they're going to hold that in place, whereas the desmosomes are going to be the lateral the lateral specializations between the cells that are holding the individual karyotypes, keratinocytes together. And so I can't say these words. Bullous pemphigoid is the hemidesmosomes at the basement membrane, whereas the vulgaris one is the desmosome. So make sure you remember that. Looks like the smiley face, yeah, on the IR fluoro. Yeah, if you reach out to me, I'll let you know where you can find that book. Most of you guys are getting this correct. I'm gonna let you some more answer before I reveal it. Oh, I like that one, Brady. I've never heard that one. Okay, we're getting a little. Okay, so this is actually going to be B, area 2. So this is where you are going, this is the area for new cartilage matrix. What zone are we in right now? Proliferation zone. Yeah, this is where you're getting that new cartilage matrix. Awesome, guys. Okay, we're between 2, which I expected. Make sure you're drawing on yourself, guys. I know it sounds silly, but make sure you're drawing on yourself because it can really help visualize which nerves are going where and which muscles they're acting on. It helped me so much. But this answer is going to be C. It's common fibular nerve. Common fibular nerve. So does anybody want to explain why it's not A?
Because you have eversion in there as well.
Yeah. Yep. This is another one from pretest. We're getting some spread on this. This is okay. I actually spent a lot of time, probably a lot more time than I should have, but a lot of time drawing out all of the proteins associated with the sarcomere. And it's very important to know where each of these proteins are located in the sarcomere and what their function is. Extremely, extremely, extremely important. Especially this one, they love this one associated with dystrophin because it's associated with a disease, so muscular dystrophy. And so this is a really good type of question that you can get with respect to this. So this is going to be, wait, did I key this wrong? No, actin to beta dystroglycan. So make sure that you understand and you can draw it out, or not draw it out, but you understand where each of these are. Okay, this is another one I hope has become very second nature to you guys. You're pretty much all getting it correct, yeah. I'll give a little more time for you guys. So first, what are we talking about here? What's this rash?
Shingles.
Shingles, herpes zoster, and herpes zoster is going to reside in the dorsal root ganglion, and it's going to distribute in a dermatome way because dorsal root ganglions are at the different spinal levels, and of course the umbilicus is going to be T10. Please make sure you know these dermatome levels. T10, T4 are going to be big ones, but please work up from there because they like the dermatomes in the hand as well. So like thumb versus pinky finger, they really like the dermatome levels up there. So make sure you don't just learn the big ones. So this is diabetes mellitus, presents with 2-week history of right lower extremity pain and swelling. And it says physician diagnosis and with cellulitis, and the patient is submitted for IV antibiotics. You'll have 1 or 2 questions like this. Yeah, y'all are getting this right. I'll give a few more seconds for you guys to answer. Yeah. You guys are pretty much getting this right. The answer is inflammation of the skin. So the word we're looking at here is cellulitis. The suffix itis refers to inflammation. So that's where you get that here. Redness is erythema. Contact irritation, that is more of a diagnosis than it is like saying the meaning of the diagnosis. But itis, you're always talking about inflammation. Pretty much all of you guys are getting this correctly. Good job, good job. It is a anterior longitudinal ligament. What would the reverse of that be? There's another ligament they like you to understand with respect to injuries. What's the other ligament? Posterior. What's important about the posterior one? Yeah, hyperflexion. So you need to know the difference between the two of those. Yeah, you guys are getting this one too. I'll give a few more seconds for more to answer. Yeah, you guys are pretty much getting this. You're going to see wrist strap. So what nerve are we talking about here? Yeah, Saturday night palsy. That's what this is. So it's going to be the radial nerve, and radial nerve, you always see that wrist strap. So it says 26-year-old 6-day status post lap cholecystectomy, has a follow-up appointment with her surgeon due to concerns that the incision site isn't healing well. There is a key word or two words here that should give you the answer. But most of you guys are getting this right. I'll give you a few more seconds. So the answer is B, migratory phase. What is a point in each of these that you would be able to pinpoint what it is? Oh, that is not what I wanted to do. Yeah, pink granulation tissue, that's what we're honing in on here. Yeah, you guys are getting this one too. I'll give a few more seconds. Yeah, you guys are getting this one right. So it's depletion of the ATP stores. You know, ATP is required for the detachment and to reset the system. So you're still contracting, all of a sudden no ATP because no cellular respiration, and then you can't reset the system. And so you have just this systemic contraction of the skeletal system, musculoskeletal system. BLE is for bilateral lower extremity. Oh, some of you guys are falling into this trap. Make sure you know the anatomy of what's actually bulging. So we're talking about the herniated disc. That's what's herniating. Most of you guys are getting this right. It's nucleus pulposus. So, you know, in the intervertebral disc, you have the annulus fibrosus and the nucleus pulposus. The nucleus pulposus is bulging through the degenerated annulus fibrosus, and that's actually what is herniating into the space. So make sure you understand the difference between those two. That's fair game on the exam. It's an easy point if you understand it. If you get the two mixed up, it's not an easy point. So nucleus pulposus. I don't have a cute way of remembering it. Maybe someone else does. I don't remember what type of cartilage nucleus pulposus is. Does anybody know?
It's actually a remnant of, well, the annulus fibrosus is a good example of fibrocartilage. The nucleus pulposus is a remnant of the notochord. Somebody correct me if I'm wrong. It should
Yes.
be
Yeah, everybody. Yeah.
It's notochord.
notochord. Thank you.
Yeah. You guys are getting this correct. I'll give a few more seconds for those who want to read through it. Okay, most of you guys got this. It's the spread inward to all parts of the muscle via the T tubules. Know that chart in, I don't remember which lecture it is, but it outlines skeletal versus cardiac versus smooth muscle. You need to know that chart backwards and forwards. It's a really good place they can pull questions from. Of course, you need to know, they like to put the electron micrographs of the area on there. So you have the triads and the dyads for skeletal versus cardiac muscle. You need to understand all of that with respect to histo. What is A referring to, guys? Yeah, more relaxation. Yeah, relaxation. Prolonged plateau phase, where do we see that? Cardiac. That's a big one in cardiac, and you'll go through that a lot more in CPR1. Yeah, make sure you read. I fall into that trap too. Everyone falls into that trap where you misread the question or you miss a couple words that completely change how you think about the question. Yeah, you guys are getting it right. I'm so happy. When I did this last term, nobody was getting it right and nobody knew what I was talking about, but they like to test this. And they usually put in IMCQs and or eSoft quizzes. It's straight out of your notes. It's just a term, honestly. I'll give a few more seconds. It's C. It's going to be 1 gram. It's going to be 1 gram. This is just straight out of the notes. So like Brady said, preload and afterload is going to be a big thing in CPR1 because it directly relates to the contraction of the left ventricle. But this is just an introduction into that concept. So it doesn't make a whole lot of sense right now because it's just an intro and there's no real application with it here. And so Brady went over some of this, but the definition is just 1 gram of preload. This is the optimum length of contraction. So you know that you have your afterload is going to be dependent on what you load it with. So the preload. So think of a spring. If you load a spring with a certain amount of weight, then that's how it's going to react depending on that weight. But 1 gram of preload, it's a definition. This is optimum length. But 5 grams of preload, it says at this length, the active force decreases. Why does this decrease? Do you know? Less overlap. So the actin and myosin has to overlap. And so if a bodybuilder can only lift so much weight before you don't have good action anymore. So just remember 1 gram. It's just a definition from here. The big concepts are going to come in CPR1. Yeah, you guys are getting this one too. I'll give you a few more seconds. Yeah, most of you guys are getting this one. Okay, answers have stopped, so I'll just give you the answer. It's Vmax. So, okay, this is actually really blurry and I apologize for that. But at Vmax, which is this circle right here on the bottom, Vmax, this is where you're getting AT pace activity is not being altered at this point. So go back to the question. So the effects of changing each behavioral, at which point is ATPase activity represented? So it's going to be that Vmax. Brady, do you remember a lot from this?
No.
But I drew this out. These are really going to be more definition based, honestly. Don't get caught up in all of the physiology of this right now. Make sure you go through your slides. Make sure you notice telling you a lot of this, like I said, is going to be definition based. So Vmax, Fmax, know the difference between those two and what they're showing you. Okay, presents to the ED with 2-day history of a headache and stiff neck. Notice when he woke up. Those are the vital signs. Lumbar puncture is performed for concerns with meningitis. Oh, I'm almost positive I keyed this wrong. I know the answer, but I'm almost positive I keyed this wrong. So it says, during the procedure, physician feels some resistance and then a pop. So this is the first pop. Okay. Okay, I didn't. Okay. For some reason, I just remember keying it wrong. But okay, you need to know this. First pop, so you go skin, sub-Q, supraspinous ligas, interspinous, ligamentum flavum is this first pop. After this first pop, you're in the epidural space. The second pop is going to be the dura mater. And after the dura mater, this is where you're getting to the arachnoid space. Does anybody know why this is important? Why we need to make sure that first versus second pop? We're talking about a lumbar puncture here. What is another procedure where you're going into the spine where you need to make sure you're in the right place? An epidural anesthetic, right? And so you want to make sure that you are in the correct space. So first pop versus second pop, you really need to understand. That's just has a lot of implications, clinical applications. Okay, moving this again. The answer was epidural because we got one pop, but CSF would be in the subarachnoid space. Okay, everyone's getting this question right. Good. It's inotropism. So inotropism just refers to the contractility of the heart by titrating the calcium levels. Yeah, you guys are getting this correct too. Yeah, so we're not talking about the initiation of the signal. We're just talking about the propagation through, SA versus AV. They can both initiate. Gap junctions. Gap junctions are the lateral specializations between cells that allow for ion transfer from cell to cell. That's what allows the propagation of the signal. This is the chart I was referring to earlier. You need to know this because they will test you on the differences between the different muscle types. It should be in your lecture. I got it from your lecture. You're gonna get this though, so you'll have it. Yeah, most of you guys are getting it. So if we're not abducting up to 90 degrees, what muscle are we talking about there? Deltoid, yeah. So initiation is supraspinatus, whatever it's called. And then up to 90 degrees, that's deltoid. So we are talking about the quadrangular space here. So I included a picture. Make sure you understand the different spaces and what goes through it, because they can test you, because there are a few in this area. And if you get a stab wound, it can go into one of these spaces, and then anything within that space can be compromised, leading to sorry, I'm just reading the chat, but leading to different presentations. This kind of goes along with the question in the chat. Oh no, I have a different one. Sorry. Hypertension is HTN. So really, to get this right, you have to have seen it in the notes and made a memory of it. And so I'll give you a few more seconds. Most of you guys are getting it right. Okay, we do have a little spread here, but it's actually C. Metoprolol is a beta blocker, and it's going to prevent calcium channel phosphorylation. So this is just straight out of your notes. Decreasing ionotropy, so a beta receptor blocker. And so it gives you the examples right here: atenolol, metoprolol, and propranolol. So if you see OLOLs, you're going to see it's going to be a beta blocker. Oh, this is my last question. Okay. So I hope you guys enjoying that. So you don't know. Beta blocker, beta antagonist is not really the same thing, honestly. You're welcome. If you guys have any questions, let us know. We can stay on for a couple minutes.
Yeah, good luck on your exam, guys. Yeah, you could reach out to us if y'all need anything. I'll have the video up. Yeah, no worries. I'll have the video up hopefully by a little later on this afternoon.
And these will be posted with the video material. So it's going to be added to the PowerPoint that Brady already went through.
And listen, trust yourself on the exam. Don't second guess yourself. All right. If you put down an answer, don't change it unless you're sure you made a mistake. All right. You know what you're doing, even if you don't think you do. All right.